And we plan to reinstall our whole Africa gallery in the next couple of years. And this Imagine Africa gallery is set up so that we can get input from you, from members of the community, about what we should put in our permanent gallery. Excuse me, getting over a cold. And now I'd like to introduce Dr. Lee Casanelli, who is Director of the African Studies Center and Professor of History here at Penn.
Thanks very much, and thanks for coming out tonight. First sort of cold night of the fall, I guess it is, after a long, warm spell. This is the second in our museum series of lectures, and I think sometimes when we're here in the middle of this great museum with its wonderful African sculptures and masks and textiles and jewelry, we may imagine Africa, you know, or we may tend to imagine Africa as a storehouse of great treasures from the past, or from some exotic kingdoms, you know, before the days when the continent was colonized by Europeans. But I think it's just as important to imagine Africa as a frontier for new knowledge and for future development, future achievements, and a place where a lot of modern people are trying to, are working on some of the same problems that we all are, trying to achieve a good standard of living, to give their kids a good education for the world economy, to stay healthy and find cures for diseases that threaten their lives and livelihoods. And that's why it's great to have Harvey Friedman here tonight to talk to us and help us imagine Africa as a place where diseases are being challenged and where healing is going on in lots of ways, lots of exciting ways. Dr. Friedman is a medical doctor who got did his medical training at McGill University in Montreal. He's a professor of medicine here at Penn, where he specializes in neurovirology, and immune evasion strategies of viruses. And he's been the chief of the infectious diseases division at the medical school, and I guess he's going to step down from that at the end of this year. Most significantly for our purposes tonight, though, is that Harvey Friedman has been the director of the Botswana-UPenn Partnership since its beginning in 2001. And in fact, this year, we're celebrating the 10th anniversary of the UPenn Botswana Partnership, with events both here on Penn's campus and also in Botswana. So it's quite I'm going to let him tell you all about that program and about its what's going on in the fields of medicine and health. And it's not just HIV/AIDS that the partnership team is working on. It's also tuberculosis and maternal health and child health and so on. There are lots of new frontiers going on with collaboration from the professionals and the citizens of Botswana, as well as with Penn students, faculty, and various other partners. Harvey has been a strong advocate for expanding this original medical collaboration into other areas beyond medicine. He always tells me when we talk, he always says, I'm just a doctor. He said, I don't know anything about African history or African culture or African languages. But he is a great supporter of all sorts of research that goes behind medical, clinical work or medical applications. He really has urged all of his students and all of us to learn more about the social conditions that contribute to the spread of diseases in Southern Africa and elsewhere in Africa as well. He is an infectious diseases expert after all. We've also talked about developing a special language program in the Setswana language. Setswana is a language of most people in Botswana. And we think that our medical students and our faculty and people who go there should know at least some minimal Setswana, to just greet people, if nothing else, to greet people in the airport, or to ask people how they're feeling, and to learn a little medical vocabulary. I mean, if our future medical students are going to be doing international health, it's really good to learn something about the way Africans think about disease, health, healing, cures and so on, and to learn a little medical vocabulary. So we're working on that, and Harvey's been a big advocate for doing these things and trying to build these knowledge bases around our medical activities in Botswana. He has great respect for his African colleagues and co-workers. And unlike many foreign experts, who go to Africa thinking that they, the foreign experts, have everything to teach and very little to learn, or who think that all the problems are there in Africa and all the solutions have to come from outside. That's the way a lot of international aid or international assistance or international programs in Africa will think and work. Harvey does not have any of those attitudes, at least that I can see or that I've ever seen. He realizes how much we, including our very talented medical students, have to learn. And he really appreciates the great value of taking the time to discover how work gets done in other places and how other people prioritize what's important. They don't like to rush around all the time without greeting and asking how you are and asking about your family. And very often our professionals, whether they're medical professionals or business professionals, are all business. Let's get down to business. Anyone who's been to Africa knows people will often take 10 minutes greeting you about all sorts of things and asking about all sorts of, how's everybody? And that's very important to build social relationships. And Harvey's aware of that. I think we're all trying to imprint that a little bit on any Penn personnel who go to Botswana or elsewhere in Africa. That's part of the function of the African Studies Center, is to give some cultural knowledge and sensitivity to people who have very good intentions and have lots of things to contribute, but also have a lot of things to learn. So at his urging, it was Harvey's urging that got me to go to Botswana. I'm the director of the African Studies Center. I have to go to a lot of different places. We have a lot of programs. He said, you've got to go to Botswana and meet with other people to see how we can enlarge and expand this partnership that started off as a medical collaboration. And so I did meet with the deans and the heads of departments in humanities, the social sciences, and the business school, and we're building on some of the exchanges that Harvey will talk about in a few minutes as we speak here. We're still working on things. So this speaker tonight, a good friend of ours who's just a doctor, as he says, has really helped to launch a whole series of initiatives to link Botswana with Penn. And he's firmly committed to education in the broadest sense, not just medical education, but the education of around medicine. And in Africa, health is a lot more than just the chemistry and the biology of illness. It's a lot about social relations and about an individual's place in a larger social universe that really matters. And even we in Western medicine, I think, discover now that it's not, you can't just give pills and expect people to get better. The environment in which they live and they heal is very important. So I think these are things that we're all learning from Botswana. Anyway, Harvey also reminds us always that Botswana has a rich oral tradition, oral knowledge, songs and poetry. Its people have great sensitivity and knowledge about their environment. They've had a lot of experience with development. So there are a lot of things that Penn visitors can go and learn about by going to Botswana, as well as bringing whatever skills they may have from here to Botswana. And that's why I think Harvey's a great spokesperson for this, for imagining Africa in a way that's not just about the past or about things that people make, but about ideas of healing both the individual body and the body politic, the healing society. So we're delighted to have him tonight, and I'll welcome him and let him tell you all about Botswana.
Well, good evening. Well, that very nice introduction, and it highlights some of the key points of the program, because when Lee Casanelli goes to Botswana, he sees a different country than I do. Not because we see the same country, but you're tuned into different parts, the cultural aspects are so important to me and you, but we complement one another. And part of what I think this program thrives on is the fact that The university is a phenomenal place. This place is really phenomenal. And my job as the director of this program is to get as many people excited about Botswana as possible and have each of you bring your expertise, your knowledge, your enthusiasm to the country to make a tiny contribution. Because that's, if we can make a tiny contribution and you multiply that by 1,000 or 10,000, we'll have an impact. So I'm going to take you through our program. I'll start with a few comments about HIV where we are today. You might notice I'm wearing a red ribbon. Tomorrow is World AIDS Day, marking the 30th anniversary of HIV AIDS in the world, first discovered in the United States. So they were reported 30 years ago. There's been 30 million deaths worldwide. 575,000 of those in the United States. 34 million people are currently infected. And those numbers are not going down. Now, one of the reasons the numbers are not going down is because we're treating patients and they're living longer. But that only makes up a small percentage of that 34 million. As you see here, 66 million people in low and middle income countries are now on therapy. Now, it's not 34 million, that's our goal for everyone. But that's a huge advance in the last few years. And you can see just in the last 1 year, the improvement that's occurred. How do people get HIV? Well, the most common way right now worldwide is heterosexual transmission. So we don't like to think very much anymore about risk factors because you can't say that heterosexual contact is a risk factor for HIV. I mean, it's normal people living their normal lives. There is still a lot of HIV in this IV drug use, and male having sex with men is still a big group, but by far and away the largest is heterosexual. We have 1.2 million people in the United States living with HIV, and there's still 50,000 new infections per year. So it's a major challenge still, trying to get the infection rate down in this country, whereas worldwide those numbers are closer to 2 million new infections annually. I thought this, I have a series of 3 slides here that graphically will hopefully make an impression. This first slide is the world landmass and you'll recognize United States, and here's Africa. So I want you to just keep Africa in mind. This is the landmass of Africa. Now I'm going to show you, if we were to show this map by where HIV is in the world, this is what the map looks like. So Africa becomes a balloon, just totally blows up. And here's the United States, here's South America. Look at the disproportionate impact that HIV has had in Africa. Now I'm going to show you where the healthcare workers are. So keep your eye on Africa. So now here's Africa. This is where the physicians are working proportionate to population. Here's the United States. So you can see the nature of the problem. Huge number of cases, very few healthcare providers. What about our program? Well, first let me give you a few facts about Botswana. Botswana was a protectorate of Great Britain until 1966. Around that time, Botswana discovered diamonds, and it was fortunate that the diamonds were discovered shortly before, or maybe just after, the Brits left. The word in Botswana is if Brits had known about the diamonds, they'd probably still be there. And I hope there's not too many British citizens in the audience. The diamonds, you know, we hear about blood diamonds and so on. Blood diamonds, don't think about Botswana. Botswana has used the diamond industry to a great advantage and has been as clean and fair about it as I think any country in Africa. The government owns they share the profits with De Beers in South Africa. Half the money goes to the government, and they have used the money to develop infrastructure in Botswana, and it's been really impressive. In the 10 years I've been going, the development of the economy of the country has changed dramatically. And it's really impressive how many buildings, roads, highways, cars, traffic. There's as much traffic in the capital city, Gaborone, as I face going to work here in Philadelphia. So infrastructure-wise, there's been clearly huge development. And diamonds is at the heart of that. There's only been 4 presidents. It's a democratic country. 2 of those presidents have been our visitors. And my wife's in the audience, and one of those presidents she fed for dinner at our house one night. So, which is, she's a bold woman. And she cooked the dinner. So there's a low corruption rate, which is tied in with the points I've made. It's a very safe country. Well, I'll say safe. It's safe like Philadelphia safe. I'd say like West Philly safe. You have to know what you're doing and be street smart. English is the national language. And when we first got into Botswana, which I'll tell you about, it had the highest HIV prevalence in the world. Here's the location. It just sits above South Africa, has the land mass the size of Texas, so it's big. It has a population of 2 million. So you can imagine that it's very rural in its setup. Most of the people, most of the patients are off in very distant parts of the country, hard access, difficult access to care. So what about our program? We got invited to Botswana in 2001 by someone in the Merck Foundation. They had partnered with the Gates Foundation and the government of Botswana. They formed a partnership called African Comprehensive HIV/AIDS Partnership. And they were looking for doctors to help them with the rollout of the national program. So that was a call that came to me because I was the head of infectious disease, and they said from the Merck Foundation, are you interested in helping us with the rollout? I was interested, and I was thinking at the time of our students, our trainees, who are asking us all the time, we want an international experience, we want a global health experience, we'd like to go somewhere where we can make a contribution. But we didn't have an infrastructure in place, or a country, or a relationship, or a program. And I thought, no, maybe this is our chance. As it's turned out, we've done well with that, but it's been so much more. Because what we really spend our time on is trying to build capacity for healthcare in the country. And building capacity that's sustainable is really the heart and soul of what we're trying to do, and it's absolutely critical. Why was Botswana chosen by the Merck Gates Foundation? Well, some of the reasons were on that first slide: democratic, safe, English-speaking. But their president at the time, Festus Mogae, said, we are threatened with extinction. People are dying in chillingly high numbers. It's a crisis of the first magnitude. This was an extremely bold statement. It came at a time when Mugabe in South Africa was saying AIDS doesn't exist. There's no such thing as the HIV virus. People were dropping like flies. He got up at a major UN General Assembly meeting and said this, and this got national attention, world attention. So that led to Merck Gates putting money into this, and we were fortunate enough to get involved. This shows voluntary counseling and testing. This started in 2000, just before our arrival in Botswana. But the country was very progressive. They opened up these anonymous voluntary counseling and testing centers throughout the country, and they thrive to this day. MASA is a new dawn. It's the name they've given to their antiretroviral therapy. This started officially in 2002. The goal was to make antiretroviral drugs freely available to the citizens of the country. And that was our role to take part. We were playing a part, not a huge, because there was many people involved in this. But we played a part in getting this going. A few comments about the statistics where we are today. Overall, the prevalence of HIV in Botswana is 17.6%, but this looks at all ages. If you look at women and they say the 25 to 49 age group, the numbers are closer to 35% or even closer to 40 in some parts of the country. So this puts Botswana about second worldwide for HIV prevalence. There's 35,000 living with HIV, and here's perhaps one of their biggest successes through the national program, the rollout. 90% of eligible patients, and the eligibility depends on how advanced your disease is based on blood testing. But 90% of those eligible are on treatment, and they're on treatment free, provided by the government. This is a disease worldwide that's more common in women than men, and that's based on anatomy. The female genital tract is more susceptible to HIV infection than the male genitalia, and this is true for other sexually transmitted diseases, but not all of them, but some of them, and HIV falls into that group. Mother-to-child transmission, here's a huge success because of treatment of women during pregnancy. 40% of the infected women were passing on the virus to their baby. Now it's down to really closer to 2% because of excellent access to care, treatment during pregnancy, labor, and delivery. So this is really a model country in this regard. But I don't want you to think that everything is good in Botswana from a medical point of view. I described the infrastructure. They've done great with commerce, roads, buildings, but they have not done as well medically. And the medical development has lagged behind, and part of that is they were slow to develop their own medical school, and we'll talk about that in a minute. Excuse me. So in 2001, we helped with the rollout, and our focus, when we first arrived in country, we said, what can we do that's different from what everyone else is doing? We weren't the only U.S. institution there. Harvard School of Public Health, Baylor School of Medicine, and pediatrics were there at the time. And we said, well, we're not public health, we're infectious disease, or at least that's how we started, and we're not pediatrics. So we said we'd start with adult internal medicine, infectious disease, focus on HIV in that population. And at the time we started working in the hospitals, in the medical ward, which had maybe 300 patients, 150 on the men's side, 150 on the women, 60% of them would be HIV infected. And they wouldn't be there just for their HIV, it's for the complications of the disease. Here's a picture of one of our students and one of our doctors making rounds at the hospital. You can see it's an open ward type hospital, which is a problem because with HIV comes TB. There's a lot of TB in Botswana, and TB in a open ward is a risk for transmission from person to person. Our program took a major turn in 2003 when we started getting U.S. government funding, PEPFAR, President's Emergency Plan for AIDS Relief. This funding was to help us train the local healthcare providers. And our funding has grown annually since then, and it is a major support of our program. And it's allowed us to recruit doctors to work in country. We have 12 doctors working in country right now, full-time. Some of them from the US, some from Botswana, some from Europe, some from South America. And they're mostly supported by our PEPFAR grant. And their role is to help train and build capacity in country. In 2006, we signed a memorandum of agreement with the University of Botswana for exchange of students for research and clinical training and undergraduate exchange programs. And that exchange program is doing really well. Here's a picture of our provost at the time, Ron Daniels, sitting at a conference room in Botswana. Here's Ron. With every single dean from the University of Botswana was at that table to discuss collaborative exchanges with UPenn. So one of the things we can bring to Botswana is the intellect that we have, our capacity, and our expertise. We can't apply it there like we do here, different culture. but we can help, sit down, talk, think, train, educate. And the more we do in country, in Botswana, the better. What happens if it's all done here is that the longer they're here, the less likely they are to go back. Here's Dr. Gutman, Amy Gutman, President, visiting Botswana. Here she's meeting with that President Festus Mogae that I mentioned earlier at his quarters in Botswana. And here she's meeting with the president of the university at their museum. So an important part of our program has been bringing leadership together from Penn with Botswana. So what are we doing there? Well, I'm going to go through a number of our initiatives quickly. We're very involved in providing care for HIV. Along these lines, we're developing national guidelines on managing some of the complications of HIV. And here, for example, pneumonia. What's the best way to treat a patient when they come in with pneumonia? We sit down with stakeholders at the government, at the university, come up with guidelines, make them available to doctors throughout the country. We're doing outreach to regional and distant sites because not all the, the patients are very spread out. So we want to send our doctors, and here's one of our doctors going with one of the doctors from Botswana on a government-sponsored trip. It's a day trip. They'll fly 600 kilometers away, see patients, hopefully teach other healthcare workers while they're doing this, and then return. And we do this weekly. TB is a huge problem in Botswana. With HIV comes a susceptibility to TB. And I said 60% of the patients have HIV, about 30% of them are co-infected with TB, active TB. So with TB, there's a lot of drug resistance TB, there's HIV-TB co-infection, and these patients are really complicated. So our expertise can be helpful in that setting. We have helped train local providers on how to take care of patients with drug-resistant TB. We've set up 4 clinics around the country where drug-resistant TB patients are treated, and we've provided technical expertise to set up those clinics. If we disappear today, that expertise is there. And that's a sign of success, in my opinion. TB, HIV co-infected patients. Right now, in most of Africa, if you have TB, you're taken care of here. If you have HIV, it's there. Different doctors. You may even be in the same building. Different doctors. Well, what we're trying to do is have one building, one doctor, so that the 7 or 8 drugs they're on for these conditions, someone knows all the side effects, someone knows the complications, someone can manage that patient and make a decision. We're trying to train. That training is absolutely critical. And not only are we training local health providers, but we're trying to provide expertise to the ministry. Well, let me just see. So here's, at Penn, if you wanted to get sputum on someone who has TB, you would send them into an isolation room for coffee. They don't have isolation rooms. So what we do is we take them outdoors into this little cubicle where they cough up their sputum, trying not to contaminate the tuggle environment. And it's our cough cubicle. Here's a child that we're obtaining what's called a gastric aspirate. A tube is being placed down the nose into the stomach. Children don't cough, so it's very hard to make the diagnosis of TB in children. How do we do it? We put these tubes down, and us doing it isn't enough. We have now trained something like 75 different sites in country for the nurses and doctors to do this procedure, to try to improve diagnosis. Women's health is a big issue for our program. We started a cervical cancer screening program in HIV-infected women. The program is simple, which fits Africa, the infrastructure. Now here, if you wanted to screen for cervical cancer, you do a pap smear. If you did a pap smear in Botswana, which they do pap smears, it's done, it can take anywhere from 2 weeks to 6 years till the result comes back. And the average is probably 6 months. You know, and if the answer comes back cancer and it's 6 months later, well, guess what? That's not so good. So the program that our program head, shown here, Doreen Ramahola-Masiri, has instituted is called See and Treat. You examine the women, you make a decision, you treat them. Now, one of the reasons treating them on the spot is important is that there's a large loss to follow-up if you send people home and ask them to come back. Now, if their home is 2 blocks away, sure, they'll come back. What if their home is in a village 80 kilometers away, which is the norm? Are they going to come back? How do they get there? There's not trains and buses, and, you know, it's not an easy matter. So See and Treat makes perfect sense. It's a simple test. They do vinegar, acetic acid, stain of the cervix. So you have to have a speculum. You examine, put the vinegar on the cervix. And if the cervix is abnormal, the tissue turns white. Depending on the size of the lesion and the depth in which it goes, which takes some experience, either it's treated right on the spot with freezing, cryotherapy, liquid nitrogen, or it's referred to a second clinic for an electrode cauterization as a way to remove a larger part of the tissue. And we have now screened 3,500 women, and 1,500 of them were treated in this See and Treat program. It's a program we started in the capital, Gaborone, and it's now rolled out to a second major city, and we're being asked to roll it out to the rest of the country. So it's a big success. And I'm going to tell you about a few more programs, but I'm going to spend a little bit on this telemedicine, because this is really taking technology to Africa, to patients, to medical problems in a way that I think really is innovative. What's the challenge? Well, here we have great internet. In Botswana, they don't have high-speed internet. They have satellite internet now, which is better than much of Africa, but it's not available throughout the country. And it's not very high speed. It's very, very frustrating, actually. But what do they have? They have cell phones. Almost everyone has a cell phone. In 2003, 61% of the world's population, not the world, of the landmass of the world was covered by mobile signals. Now it's 90%, or in 2009. Now, what about citizens? Well, in 2000, 25% of the citizens of the world had a cell phone. Now it's 75%. And if you go to Botswana, you'll see that virtually everyone has a cell phone. They don't have internet, they have a cell phone. So how do we take advantage of that? Well, here's a picture of a provider holding a smartphone in his hand, or her hand, and there's a camera in there. And that camera is a high-resolution camera. They're going to take a picture and send that picture to the specialist, who may be 500 kilometers away. And it's a way to access limited resources, few health specialists, but from a distance. So we've done this with oral telemedicine. For oral disease, there's one surgeon, dental surgeon, not a dentist, but a dental surgeon, to do serious surgery in the whole country. So we've used this program to make his expertise available. Cervical cancer screening. We have one doctor who knows how to read well those vinegar stains. We've taught a lot of other people now, but then the decision to do more or less, she's the expert. Rashes lends itself beautifully to this technology. You have a rash, you're not sure what it is, take a picture, send it to a dermatologist. There's only one dermatologist in Botswana, but there's lots of them here. And Carrie Kavarik has pioneered this program. Actually, all of these issues that I'm talking about have come out of her program. She's a dermatologist here at Penn. She'll sit at her office, read the rashes. There's also now, through training, someone in Botswana that can read those rashes. Radiology, and I'll show you an example of that in a minute. So let me take you through a few of these. Oral telemedicine, we have, the cell phones here show the sites that are currently set up, and the ones in shadows are the ones that are in process. But we have cell phones, high-resolution cameras at 6 locations, 13 clinicians trained. We've now sent 107 cases that we've assessed by this program, where the dentist or dental surgeon is sitting in his office in the capital city. Radiology. We've set up a program at 2 sites, more, this is the map of Botswana, more to follow. 54 cases. So what do we actually do here? Well, this is the old system. So here's an X-ray, or it's actually a CT scan that was done at a district hospital in the middle of nowhere. Now, for them to get, there's no radiologists. There's not many radiologists in the whole country. There's none for sure at this district hospital. So for them to get someone to read it, they have to the ambulance takes this film, drives it to the nearest radiologist, the film gets read, and then gets reported back. Average turnaround time, 2 weeks. So what are we doing now? Well, they don't have the capability for internet digital transmission, so we put the film on a view box, take a picture of it, send it by cell phone to the 2 radiologists sitting in the Capitol, and they look at that film, and they text message their result back. And the turnaround time, hours or minutes. And this is really a beautiful example of how you use technology. We're also using this with our library here at Penn. So African studies, one area for expansion. Penn's library has stepped up and gotten involved. What we've done with the library's help is we've been able to put Penn's library onto the smartphones of a number of the trainees in Botswana. We provide them the phones. They want to look, they're in the rural areas, seeing a patient, not sure what to do. Here, you know, what we would do is we'd have access to the internet, look up information, the latest textbooks and so on. So we put it on their cell phones so they can get access to this. And they have the information, at least at their fingertips, and much appreciated. So we have the phones with medical and drug information, and where we've used this, there's, I'll tell you in a minute, they've started a new medical school, so internal medicine, pediatrics, emergency medicine, and so on. We've put these phones throughout the health system. And we got nice recognition for that. This is in June in the University of Botswana News. UB School of Medicine and UPenn pilots Telemedicine learning project, which we were pleased to see. Medical education is key and central to everything we're doing. We're talking about patient care, bringing access, building sustainability, and so on. But in 2009, UB started their first class. Up until then, the government was sending students to train abroad, South Africa, Great Britain. 50 students a year left the country, 10% returned. They said, this is not sustainable. It was fully supported by the government. So they said, let's start our own school. Great idea, very difficult to pull off. And this school is 3 years old now, and we're putting our heart and soul into helping them in any way we can, but it is a struggle because they have students, and a growing number of students, and they have still very, very few teachers. And so it's easier in the early years when the students are sitting in a classroom, one teacher can do a lot. When the students start to show up on the wards and there's no teachers, it gets to be a much more complex situation. But we are participating big time in teaching, both in the classroom and the wards. Here's a team of UB students, Penn student, Penn physician examining the patient. Here's one of the Penn radiologists who is over teaching radiology at one of the conferences. Finally, I think our global health experience, we have the summer internship that's run by Heather Calvert, who's in the audience today. 15 undergraduates, mostly undergraduates, go every year and do things that have nothing to do with medicine. They may work in an orphanage or in a school or do something in finance. And the goal is to pair up the internship with the interests of the student. We have 24 fourth-year Penn students who go for 7 weeks at a time in groups of 3. We have the medical residents that go for 4 weeks at a time or 5 weeks at a time, and a summer course for 8 nursing students that go for about a month. So a robust training experience. This is a picture of one of the apartments or flats that we rent. We can house about 30 people at any given time, not in one flat, we have 4 of them. We don't crowd them in that way. So in summary, our program is focused on building capacity. That's our key mission. I can't tell you how easy it is to say build capacity, how difficult it is to really do it. Because if it were easy, they would have done it long ago. They wouldn't have needed us. And it's a painstaking process, one step at a time. The progress is slow, but that has to be the focus. Keep your eye on building capacity that's sustainable. Now, there's so few healthcare workers, it's hard to train if there's no one to train. Sure, we can take care of patients. That's not building capacity. That's treating people. Important, but that's not sustainable. So we're working very closely with the School of Medicine to try to build sustainable capacity, because that makes sense. They train their own doctors. That's the ideal solution. And that's what we're trying to support. So thank you. Visit our website for more information. You can find out about our program. And if you make a donation today, it should be to the museum, tomorrow to our program. Okay, thank you.
Thanks, Harvey. I'll let you field your own questions. Maybe.
Yeah, I'd be happy. We could turn the lights on, perhaps. I'm happy to take questions. Yeah?
You mentioned that you use the see and treat method to deal with the problems with the pap smear, and how that sort of came back much sooner than was helpful. But I was wondering why not address what some of those obstacles were. Like, what was it about them that made it?
Yeah, well, that's a good question. So the question is, rather than come up with a new program, see and treat, why didn't we just figure out how to make pap smears work in country and do that? And actually, the government of Botswana, I remember sitting with the lead civilian, it's the permanent secretary of the ministry, the highest ranking civilian position in the ministry. And he said exactly that. I don't want to do the see and treat because we could hold ourselves to the highest of standards. And if pap smears is what the Western world is using, that's what we want to use. And he basically was very resistant to supporting the see and treat program. The U.S. government wanted to support it, and they did. And he had to sign off on it, but he made us start as a very small pilot project. So why couldn't we develop? Well, it takes time to read. You need pathologists to read the pap smear. They don't have enough pathologists to read the pap smear. They just don't have them. And the pap smears would sit on, I remember going into what's a porta-cap. It's like a trail where all the pap smears would go through Haveroni to this porta-cap. They were piled up higher than you could see, waiting to be read. So so that's one example of the infrastructure not being there. They didn't have the pathologists. They didn't have the incentive, perhaps. I mean, they had pathologists. They have probably 2 in the Haveroni, but here we probably have 8 pathologists that just read the cytology. There, they had 2 to do everything. So part of it is just the infrastructure.
So would you see the see and treat program maybe more as a stepping stone towards that? There may be other in-between steps. Now we have good ways of testing for the virus, which is the cause of cervical cancer. Cervical cancer is caused by a virus, the human papillomavirus. And there are tests that are available now that are becoming almost bedside. I say almost, but they're soon to be bedside tests where you can test it
and get an answer quickly. Right now it takes about an hour to get an answer. With the HIV test, you can get an answer in 5 minutes. If we can do that with HPV, which is the human papilloma, then it will become a faster screening test, but that could bypass the pap smear entirely. So I think that's the way Botswana will likely go in Africa. We'll have the HPV test as a way to bypass the pap smear, rather than try to develop the infrastructure. But your point, the general point of the question is, do you try to reproduce what we have here, or do you say, look, we can't do everything that we have here. Let's make the best we can there. And that's really probably almost always the right answer. Yeah.
I've never been to Botswana, but I've been to other little places in Africa where cell phones were very prominent, but they would only charge it as they needed it. So is that, who's charging the cell phones? Is that our issue really well?
Yeah, so the question is, yeah, cell phones sound good, but do people have the money to really use them properly in a sense, really, because they'll charge it as they need it? We'll find out. I think in our program, we provide the cell phones, so it's not an expense for them. Were this but again, we're talking about healthcare providers having, a lot of the stuff we're doing is with the healthcare providers. There's also a lot of programs that I didn't talk about that are going on in Botswana and elsewhere, where they're using cell phone technology to remind patients it's time to refill a prescription, for example. So receiving a message is free in most countries, at least it is in Botswana. Using the cell phone to make a call is expensive or more expensive. So it's a matter of trying to figure out how to adjust the technology for the economy. We're using it as an educational tool. It's also being used as a improvement, adherence to therapy, that type of thing. And I think in general, it's still a move in the right direction. But your point's well taken. Yeah, Heather.
The other thing is, in Botswana, all of the major cell suppliers have agreed to supply airtime for free for clinical use. And so they've all signed on for that.
Is there a plan to roll out large-scale vaccine programs, for example, HPV vaccine?
Yeah, so the question is there a plan to roll out the HPV vaccine program? That's what you asked, right?
And other vaccines.
And other vaccines. Well, many vaccines are available. Not as many there as here, but in Botswana, most of the common childhood vaccines are available. Influenza vaccines available, measles, mumps, rubella. They don't use the rotavirus for gastroenteritis. It's a new vaccine. They don't use the shingles or chickenpox vaccine, and they don't use the HPV vaccine. Now, the reason they don't use the HPV vaccine is money. And it's a very expensive vaccine, but 10 years ago, HIV drugs were really expensive. And through national, international advocacy, HIV drugs are now very affordable, much more affordable than they were 10 years ago. So what can we do, we as a world community, to bring down the price of HPV vaccine? I think we can do a lot. The pharmaceutical companies have made available a limited number of vaccines for study purposes, but governments are reluctant to jump in because when those studies are over, what happens next? So, but they need an HPV vaccine. We're in the process of starting up an HPV vaccine trial in Botswana. I didn't talk about the research going on in Botswana. We have a lot of research going on in some of these areas, but it's a money issue, and those of you who may have an interest in health policy and health economics, there's lots to sink your teeth into. Yeah.
Harvey, Botswana seems to be one of those countries where people are happy to be in. People aren't fleeing the country or trying to go away, but yet you noted that professionals often will leave. Is that because of salaries or because of working conditions?
Yeah, a good question, and it's true. They were leaving. But, and it's, I think with the new medical school, the hope is that the quality of the medical care will improve. It hasn't yet. Despite, I mean, it has improved over the 10 years we've been there. You know, it's definitely improved. It hasn't gotten to the point where I would like it to be. But to retain top, you know, smart people, they want to be in a place where they're thinking, using their brains, seeing things happen, not frustrated all the time. Botswana isn't there yet. So one of the reasons they're losing people, or people aren't coming back, is when they're practicing medicine there, it's not stimulating. The other piece is the finances. And the pay level in Botswana is better than some other areas in Africa because it's a richer country, but it doesn't compare to South Africa, for example. And if someone wants to be in that part of the world, they'll choose South Africa over Botswana. So the pay is low. And, you know, we're advocating for better pay for medical personnel, but it's a real uphill battle. Yeah.
Yes, you kind of touched on this before. You said that economics is a problem. I was wondering, with dealing with the people and learning about the culture, did you learn any natural remedies to these problems?
Yeah, well, that's why I sent Lee Castanelli there. I need him to learn the natural, but your point is an interesting one. The question is, have I learned any natural remedies? Almost every citizen in Botswana will see a traditional healer, and if they're going to see, they may only see a traditional healer, but they'll see a traditional healer and they're a Western doctor, you know, Western trained doctor, or, you know, maybe South African trained. But it's the norm, and I was told that it's probably in the 90 to 95% that people will do that. A very interesting question is, what impact does the traditional healers' recommendations have on the recommendations we may be making? It's an important question. People are studying it. We know very little about the impact. We are studying what the complications may be of traditional medicine. So one of our pediatric colleagues is very interested in how there's very common that children will get diarrhea and they're not sure what the cause is. And some of the concern is that it's some of the traditional medicines being used. So there's studies of that. There's a high incidence of kidney failure in kids. And some of the concern is this traditional medicine? That doesn't really address your question is, have I evaluated traditional medicine and have a personal understanding? The answer is, I have been remiss in that area. But it's an important thing for us as a culture and us as a group to understand as it goes on life. Yeah.
With so many high-powered institutions in a country that only has 2 million people, is there ever any issues with sort of over-studying or over-researching the HIV positive population, and how do all the institutions work together to avoid that?
Yeah, it's an interesting question too. You know, Botswana is fortunate in that they have attracted a number of excellent institutions. I mentioned Baylor, Harvard, and Penn. And we're not alone. There are others, but we're probably the 3 largest, most prominent. And are we stepping on each other's toes, and is there competition and so on? That's what you're asking.
Well, how do they make sure that the population isn't suffering by being overly researched? You know, yeah. In this trial one day, then in the next trial.
Yeah, well, one of the things that's happened in Botswana, so that they're not being overly researched, and we're not driving them nuts yet. Well, one of the things that's happened is that they have a very strong human subjects committee now. They had none 10 years ago. Now they have learned because of Harvard and Penn and Baylor and others others, that they need to have an IRB, Institutional Review Board. And the Institutional Review Board is very protective about things along those lines. They look for two things. One, is this study really going to help our country? And two, does the study include investigators and scientists and researchers from Botswana? They don't have to be citizens of Botswana, but people working in it. And if we're not doing those things, or others aren't, it's not going to get past the review board. So it doesn't mean that it's perfect, but we're sensitive to that, and it's the right answer that they push that, and we try very hard to be collegial with our not just Harvard and Baylor, but with this the ministry, the funding agencies, everyone's watching over our shoulders. Okay, I think we're done.